Thank you for that lovely, lovely introduction. And it's really a pleasure being here today and having the opportunity to talk with you about our work to predict and with the goal of improving language after cochlear implantation. And here is my disclosure slide. And I have to share with you that when I was recruited to Lurie Children's Hospital to start an implant program, at that time cochlear implants were not yet FDA approved for use in children. They were initially approved for postlingually deafened adults. It was in 1991 that I performed the first cochlear implant on a child in the city of Chicago. And at that time, my team was me and Christy Groney, my one audiologist. So our team has certainly grown since that time. We implant children from across the spectrum in terms of socioeconomic status. And we also were really on the leading edge of implanting children with multiple disabilities. And I'd like to say that in addition to our wonderful pediatric audiologists and oral HAP specialists, also shown here are our social workers and our educators, who I think are really important to not to getting both children through the system, because many of our children are from challenged families as well as being challenged themselves, but to help them with the challenges afterwards, be that the right school program, getting back to us, and sometimes having a place to live. You know, life is very complicated. I also need to acknowledge Patrick Wong. Patrick, I had the great fortune to meet about probably 13 or 14 years ago when he was faculty at Northwestern in Communication Sciences and Disorders, and we randomly met at a cocktail party. Each of us didn't know the other one existed. We began collaborating. And Patrick is now at the Chinese University of Hong Kong. He's been there for about 6 years, and we've continued our collaboration since that time. We recently were awarded an R01, and that has allowed us to expand our work in many ways. And listed on the bottom of the slide are our collaborating institutions and primary investigators I'd like to acknowledge. Okay. So as hearing specialists, we tend to focus on the ear. However, the success of implantation lies as much on the brain. And understanding speech really requires the brain to do the heavy lifting. There's both bottom-up and top-down processing. So the incoming auditory signal, the bottom-up processing is necessary. You know, that allows you to immediately perceive the stimulus and pull out the various features and send it up the line, where top-down processing involves the brain applying past experience, knowledge, and meaning, and that combination is what enables speech perception. Evidence of the brain's involvement it can be seen in postlingually deafened adults, and this is from a paper of Blake Wilson's that's showing the trajectory of speech perception over time, and you can see it takes quite a bit of time for speech perception to develop and plateau. If we were providing the deaf ear in these postlingually deafened adults, if we were providing them with as much hearing as you and I have, you would see immediate improvement. But because of the need to recode the information, which requires neuroplasticity, time is necessary. So this is a child who really inspired me early in my career to think about neuroplasticity, although I don't even know if I knew that word then, but certainly was thinking about what must be happening. And normally, the cochlear nerve bundle, when we look at it in the lateral aspect of the ISC, we see the four nerve bundles, and the cochlear nerve is 90% of the time is the largest bundle. This child, you can see the cochlear nerve is very, very small, and this was a bilateral finding. And I remember, like it was yesterday, calling this lovely family and telling them that based on this recent imaging that I didn't think their child was a candidate. And in those days, it was considered an absolute contraindication to cochlear implantation. And I remember, by way of context, this is a family that had to fundraise in order to have the surgery done. They had accomplished that because it wasn't covered by their insurance. And the father said to me, "But Dr. Young, my auditory verbal therapist says that my child does sometimes respond to sound." And so I did something very remarkable. I looked in the chart. And here we see the aided audiogram. And this is not this high frequency aided response is not a vibrotactile response. So something was going on. So the family and I, I'm not moving ahead. Oh, there we go. The family and I agreed to move ahead with the understanding that we really don't know what's going to happen. But since I'm operating on a human being and not an MRI or an X-ray, that's what we would do. And so I'm going to show you this young lady at age 8. She's been using her implant for over 6 years. Let's see if I can figure out how to get this video to play. There we go.
Did she have a normally formed cochlea, Nancy?
She had it was somewhat hypoplastic. She had an implantation of, I think, about 16 electrodes. So it was a reasonable cochlear duct length, enough for multi-channel programming.
I don't know. Rosie, can you sing your song for Miss Beth?
You are my sunshine, my only sunshine. You make me happy, and stars are gray. And I don't know, dear, how much I love you. Please don't take my sunshine away.
Awesome! All right. I heard that one time your mom got really sick.
I gotta stop and go back. I gotta give you some context. Sorry about that, guys. So the next video is Rosie being interviewed, telling a story about what recently happened when she woke up from a nap that she was taking with her mom.
I heard that one time your mom got really sick. Can you tell me what happened?
Yeah,
What happened?
because Mom can't wake up.
What number did you call?
911.
How did you learn to call 911?
Because I'm a superhero girl.
And another thing I want to point out about this child, and you'll see it in the next case too, for those of us like Dr. Jackler, who were around in the pre-cochlear implant era, she has what I would call deaf speech. It just has this sort of flat quality. I don't know what a speech pathologist, how you would describe it, but it's clearly someone with a significant hearing loss, which we don't see in our young implanted kids who have normal nerves. You know, it's very hard to tell. And the other thing is you could see her hesitation. She has to really think to answer the question. It's not fast like us, and that's because she's getting so little data. She's using everything she's got to figure out what's happening. And you'll see that's why I had to edit it. You'd be so bored if I didn't cut it up because it's so slow. So she did develop quite good open set speech perception, but it took quite a bit of time, much slower progress than our children with normal nerves, and that's something that is important for the parents to understand, because otherwise they're going to stop using it, and that doesn't bode well for success. And so that their services, their therapy services, are not withdrawn. So I think counseling is really important. So this is another child. This is a child who was an unremarkable history, and her ABR was consistent with auditory neuropathy, and most of our bilateral auditory neuropathy kids based on ABR have normal nerves, but there's a subset that do not, and this was this young girl, and her CT was normal, and she made progress fairly rapidly. I'm going to play her video, and I think you'll see some of the things I was talking about before with her speech and some of the thinking that's going on. Oops, I'm not doing well with this. Here we go.
I have a quick question for you. Nancy,
Yeah.
I have a quick question. Like this particular case, you saw bilateral cochlear nerve deficiency on MRI. How frequently do you see that with normal IAC and CT? So you're saying here the CT.
Yeah, it's not uncommon. And so nerve deficiency is underdiagnosed if you don't get an MRI. And there's actually some really good papers that started in the MRI literature reporting that. And it really came home to me now in the era of single-sided deafness implantation, because when I started there, we didn't do MRI. I mean, the resolution wasn't there. And so on our SSD kids, we'd get CT, and most of the time they were normal. But yet the rate of nerve deficiency in SSC is extremely high. So MRI is really key. Now, I'm having trouble. This one may not play. I'm not sure why. It's interesting. Well, you know how that goes. The best laid plans. So we'll move on. So how is this possible? So obviously the brain is making use of a very sparse signal, and the nerve may be in some cases not visible at all because it's below resolution of the MRI, and all MRIs are not created alike. And then if the nerve is indeed absent, there still is the possibility that there could be stimulation, because stimulation of the vestibular nerve could, in theory, result in auditory stimulation. That's true in animal models. And there's also the possibility of direct stimulation, or it's not really direct, but we're turning up the current levels very high in these kids, and it is possible to be stimulating the cochlear nucleus, something that I learned from Dr. Stankovic. There's a thesis at Mass Eye and Ear that showed that. So Einstein has said that the most beautiful thing we can experience is the mysterious. It is the source of all true art and all science. And I think that's very true, because mysterious is why we have questions. And for me, much of the joy in my practice comes from outcomes of implanted children, especially when the children we expect to do the least surprise us, not just by how much, but sometimes just by the ways in which hearing improves their quality of life. And this is really what sparked my interest in neuroplasticity and our research, and why I'm so grateful that I have the opportunity to collaborate with Patrick Wong. So this comes from the largest NIH-funded outcome study of young children with cochlear implants. And this is our neurotypical population, not the kind of kids we were just talking about. And even though it's amazing what these children do with a cochlear implant, if you look at children with typical hearing, their average language outcome is below that of normal hearing children, and only a subset are on the same trajectory as normal hearing children. So it's been known, 30 years of research going on in terms of prediction of outcome, and it's known that age at implant and residual hearing are important predictors, but these predictors only fare well in regression analyses with large sample size, and alone they don't account for the majority of the variance, and I suspect that's why they don't do well on an individual child level. So Patrick Wong has long been interested in variability of language outcome and in using neural predictors to forecast on the individual level, and to do so using information gleaned from MRI, FNIRS, EEG, any sort of brain imaging technique. And the goal is to use this information to develop brain-specific training to improve the outcome. It's important to keep in mind that cognition alone does not guarantee success in learning in general, that it's best to tailor learning to the individual. And he actually did early on some really interesting research on adult second language learners, and was able to show that there were different brain types, and that he developed training specific to the brain type who was able to show an improvement in their second language learning tasks. And it's also important to remember that language and cognition bootstrap one another, so providing early intervention through an implant not only positively impacts language, but cognition. So, so we hope to, our goal is to develop what we call a predict to prescribe approach to language disorders, including children with hearing loss. And, many of our meetings, there's a lot of research and a lot of talks about improving the outcome by improving the acoustic signal. So surgical electrode arrays and surgical techniques that preserve residual hearing or that preserve the structure. There's also more papers coming out now on programming techniques to improve the outcome. I think what you don't hear a lot about, there's not enough work on, is what can we do to help the brain do better with the information we are prescribing. Okay. So we want to improve processing, both top-down processing of the acoustic signal with brain training, but it's important to keep in mind that prediction based on brain structure, it might be able to enable forecasting on the individual level, but we have to keep in mind that brain structure in our children with hearing loss might in and of itself be impacted by the presence of hearing impairment. But if we can achieve individual level prediction, we then could potentially determine what are the optimal types and dose of therapy based on the brain type. So we began doing this research using enabled by machine learning. So we started with the T1 neuroanatomical brain imaging. So that's the type of brain imaging that many implant centers are using pre-implant on their candidates. And that gives us information about volume, tissue density, and surface area of the brain. And there's a two-step research process. So first we needed to compare the neuroanatomical development between normal hearing and hearing impaired implant candidates, because we wanted to know what regions were affected or unaffected by hearing impairment. And then once that was known, models could be built relying on the brain regions that were either affected or unaffected by hearing impairment to determine which best predicted language outcome. So our initial study, we had 37 kids from Chicago, under 3.5 years of age. They were neurotypical kids, with good anatomy, and they were compared to normal hearing children from an NIH brain database, and they were matched by age, sex, and socioeconomic status. And in terms of the type of analysis that was done, both the density of the gray and white matter and the patterns of the brain across gray and white matter were analyzed, and between group differences were looked at, and primary auditory cortex was found to be most affected by hearing impairment. So then using using the SRIQ, the speech reception index and quiet, as our primary outcome measure, and that for these children, because of their age, that was at that time that was the MACE. And you can see this graph shows the pre-implant and 6 months post-activation, and you can see there's quite a bit of variability. So then brain templates based on affected and unaffected regions were created, and machine learning was then used. They were trained and used to be able to, trained to become neuropredictive models, and then they were used to predict individual child outcome. And so we looked at, there are different ways of looking at the results, but this is a binary classification looking at how well did our models actually do in predicting outcome. So half of the children are classified as high improvers and half as low improvers, and how would our models do. But first, we also used age at implant and residual hearing to predict the outcome, and chance would be 50%. So using those factors, better than chance, so there was some predictive ability there. But when you look at the models that were based on neural predictors, the results were much better in terms of sensitivity and specificity, and the unaffected brain, in fact, did a much better job at predicting language outcome, and the unaffected brain was the higher level above the primary auditory cortex. So we concluded that the T1 images were more accurate. Were more accurate in classifying candidates into better and poorer improvers than traditional variables. And we did try combining traditional variables with the neural predictor models to see if that improved the prediction, and it did not. The neural prediction alone did as well as when combined. And that preserved regions of the brain unaffected by hearing loss were most predictive, and these were mostly the higher level auditory cognitive regions outside of the primary auditory cortex, primarily the auditory associate cortex and association cortex, and the dorsal auditory network. And then we've also looking at DTI pre-implant, and because this gives us information about the tracks and connections in the brain, so the information is complementary to what we obtained from our T1 neuroanatomic scans. So these are predictive brain connectivity maps. So the brain areas that predict pre-implant baseline are shown in blue, and the brain areas that predict improvement are shown in green, and red is the overlap, which is almost non-existent. So the regions predicting baseline don't overlap with those predicting improvement, which is in line with our thinking that unaffected higher level auditory and cognitive regions are essential for improvement. And this just shows the data in another way, that the models had better than 90% specificity and sensitivity, both for baseline and 6-month improvement. We recently looked at the question of does amplification prior to cochlear implantation preserve gray matter of the auditory cortex? Okay, so what we did here is we took cochlear implant candidates with non-progressive bilateral sensorineural hearing loss. They had families using spoken language. They had no additional disabilities that would impact language. They had no gross brain malformation. They had received hearing aids and oral habilitation. They had a 3 Tesla neuroanatomic MRI prior to implantation, and the audiologic data was pure tone average and length of hearing aid use at time of MRI. And we had 103 kids. The mean age at MRI was 16 months. The mean length of hearing aid use was 8 months. And the mean PTA across both ears was 100 dB. So these are very deaf kids. These are not kids with much residual hearing. And they were compared to a control group of normal hearing kids from the NIH brain data bank. And the analysis done was to look at preservation of gray matter in cortical regions of interest. And this was done by comparing gray matter density similarity between the implant candidates and the normal hearing groups. And the areas of interest included Heschel's gyrus and the superior temporal gyrus of the primary auditory cortex. And the effect of pure tone average and length of hearing aid use was examined using multiple regression analyses, and main interaction effects were further examined with machine learning. And our main finding was that there was significant preservation at Heschel's gyrus on the left, with longer hearing aid use being associated with better preservation, but only up to a year. So the longer time they used the hearing aid before the MRI, the more brain preservation in this area, but only up to a year, and then it dropped off. And interestingly, there was greater preservation for children with less residual hearing, so the very deaf kids, and that's reflected in this upslope in the first 12 months compared to the relatively flat curve with the better hearing kids. But even though when you say better hearing kids, these were all kids with significant hearing loss. So we concluded that amplification positively impacts structural preservation of the primary auditory cortex, and that's despite, if you're familiar with some of the newer research on audibility and aiding kids based on their auditory audibility index, these would be considered ears that don't have a significant audibility index. Yet, despite that, the act of aiding them, giving them some degree of detection, seems to have helped with preservation. And we think this supports the concept of both early amplification and early implantation of children with sensorineural hearing loss. So next steps in our research, or current steps actually, are we want to expand the prediction window to 5 years and enabling hypothesis testing of a new theory of neural readiness for spoken language development, which takes into account the more complex aspects of language development. We plan to compare predictive models of English learning children to Spanish learning children. And we plan to build models based on data at different implant centers across the U.S. in order to determine the generalizability of our prediction method that's used in Chicago. We also have a treatment arm, and that's to evaluate if intensive coaching of parents and communication support strategies can lead to larger language gains in children predicted to have poorer language outcome. And the strategy that's being used is called Parent Implemented Communication Treatment, PICT. And that strategy has been studied by Megan Roberts at Northwestern RPI, and that's been shown to be an effective strategy in improving language outcome in children with cochlear implants. So we hope that that a predictor prescribe approach will enable brain-based prediction and be the first step towards personalized language learning for children with hearing loss. And prediction is a powerful tool that may permit determination of optimal type and dose of therapy. It's also a bit of a frightening tool, and it brings to mind the saying that was first made famous and then abandoned by Google, which is "Don't be evil," because prediction should not be used to deny care in the name of cost effectiveness. We hope that this will become a future standard of care to customize the intervention to improve outcome. It has the potential to improve counseling and therapy planning, advanced implantation, hopefully reduce the number of low performers, and even be cost effective by efficient allocation of resources after implantation in terms of behavioral intervention. I'm going to leave you with this video of and story about a young man that I implanted, and he actually said he made this video and sent it to us a number of years ago. And he was extreme preemie. He was at high risk for learning disorders, and his first year was implanted at age 2. And by way of context, before you see the video, I think it's important to understand that implants don't give a lot of information about music. That studies in post-lingually deafened adults show that they have good rhythm perception, but melody and pitch perception are usually quite minimal, if any. And the other thing I have to share with you is when I saw this video for the first time, I was a little bit horrified because when he starts talking, I couldn't understand what he was saying. But that's because he's speaking German, which I don't understand.
Hallo, ich heiße Minnesota. Ich bin 14 Jahre alt. Ich komme aus Chicago, Illinois, aber ich wohne in St. Louis, Missouri. Ich habe 2 Implantate. Beide von Frau Dr. Young. What just said there was in German. I've taken German for 3 years in middle school. Here it is in English. Hello, my name is Raymond Soto. I'm 14 years old, and I'm originally from Chicago, Illinois. But I live in St. Louis. I have 2 implants, both from Dr. Young. I'm very thankful that I can hear music now since my implantation. And what you heard earlier was the violin. That's me playing the violin.
Soon after this video, he actually was accepted to a very competitive orchestra. I personally think he would have great potential as a filmmaker. But he's actually now in college. He's at Embry-Riddle Aeronautical University, where he's studying all sorts of aerospace engineering.
Oh.
And that's my last slide. So thank you.
Beautiful. Any questions?
Well, we've got several.
Hi, I have a couple questions. I was wondering if we can look at your DTI slide. So I'm so curious about what do you mean by prediction? Are you imaging these?
By what?
The right side, there was something about predictions after 3 months or 6 months. Are you imaging these children after?
No. We're imaging them pre-implant, and then building models you train them, like, you train the model, like, this kid got this result, this kid got this result, this kid, and then you have your model, and the model is then naive, and you give the model back the brain image, the DTI, and then it will predict this will be a high improver, this will be a low improver based on the data that you trained it with. Okay. Which
So
is
what
limited,
exactly-
Which is why we need a lot more. So these are summary. I guess the best way to say it. You have to realize I don't do the analysis. That's what Patrick is. He has a massive lab full of PhDs. But these are maps that summarize all of the data that they were fed and looked at, and then well, I should say that actually these maps were from that had all of the data and looked at which areas of the brain were most predictive. So that's the simple way to say it. That's the way I understand it. So the areas in blue were correlated with prediction of baseline. So what their MACE scores were pre-implant. And so it makes sense that the primary auditory cortex would have a lot to do with how you're going to score pre-implant, right? Because that's your detection. But post-implant, if you think that the higher level areas of the brain are going to be more important, it would make sense that different areas of the brain would, and in particular those areas, would be more predictive of outcome. Who's a high improver versus who's a low improver, that sort of thing. So,
I have a follow-up question to that.
Yes.
Are you finding that you are getting more information from the gray matter than the white matter DTI auditory pathway information?
I don't think we know enough yet. That's a great question. I don't think we have all of the information yet, and I suspect it's going to be depending on what you're asking and what technique you're using. So that's why, this is, these are tantalizing. This is not the whole story, and there's people working on this, all over the world. So these are just little glimmers, and this is not the last word by any means.
No, it's really exciting, and thank you for sharing it.
My pleasure. Yeah.
Do you think, with regard to, I think, if I follow this correctly, you saw your biggest effect, say, in association areas and things of this sort. Do you think that is due to some sort of cortical reorganization that's occurring there, or that could be responsible for, say, the differences in volume, or do you think it's just some of the developmental aspect where these parts aren't being adequately stimulated, and therefore you just don't have the brain development there? Because those are different mechanisms at play there. So do you have an idea as to kind of what might be driving that?
Yeah, I don't, and I think that one of the things that would be really helpful, which is why we're going to be exploring, not with this grant, but we are already exploring FNIRS, because you really want to be able to image the brain after implantation to see what's happened, and then I think you'd be in a better position to answer those kinds of questions.
Hi Nancy, can you say something? This is a great talk, and it just brings up so many important and interesting issues with pediatric development and implantation. Could you say a little bit about where the role of auditory brainstem implants falls in your thinking about this? Do we have a good way of predicting which children are going to do better with that if they have cochlear nerve hypoplasia?
I don't think we know that. And it's really kind of a clinical conundrum. I presented a case to the residents where I actually had a kid who was, the most unbelievably, I could show you, if we have time, I can show you the anatomy. It'll blow you away. A very unfavorable anatomy, and I implanted her at age 3. She was adopted, and so she came to us soon after she was adopted. But I think it's really, here she is. So her other ear had no cochlear. And this ear had just a little bud, okay, that's all. And it was wide-eyed. I knew she would have a CSF leak, she did. And you can see the MRI, there's a single nerve. And there was a partial insertion. That's all we could get in, okay? And I really didn't expect her to do very much. After 6 weeks, she was detecting S, okay? And the mother enrolled her in the Moog Oral School. The mom moved there. The dad stayed in Illinois. And this is her doing therapy with mom. This is a year and a half. At this point, she has a closed set speech disorder.
Yeah, I like this kitty cat.
It's not Peter.
What is it?
Big.
It's elephant.
It's big.
That's right. Oh.
And then her device, after a couple,
Yeah, I like.
about 3 years failed, and this is why I think of this case. This is a few of my patients that has an ABI. So the device failed. It was completely ossified, that little bud. Drilled it out, reimplanted. Too much facial stem. Can't benefit from the implant. So Tom Rowland did an ABI, and he was kind enough to send me this picture, and this is a tiny eighth nerve plastered on the facial nerve. And she had open set within 3 months. So in this case, having that auditory experience with the standard implant really helped her. Even though she didn't get her ABI until age 9. But there's that conundrum of how long do you wait? Because some of these kids, the progress can be very slow, and they're not usually hearing S in 6 weeks. Okay. On the other hand, the results of the ABI are not exactly absolutely fabulous. So, and I don't think anyone has the answer to that. It's a great question.
Thank you.
Before the DTI results, you showed the standard MRI results, and you showed that the non-auditory areas seem to be most predictive for the baseline and how they do after the implant.
No, they're non-auditory. Areas not affected by auditory deprivation, and they were the higher level. They were sort of the next level up, shall we say? Above the primary auditory cortex.
Okay.
But they're normally involved in developing speech perception. That's a higher level function. Yeah.
That makes more sense.
Yeah, I'm sorry for those.
No, and I was wondering what changed about those areas, because what we pick up on MRI is,
No, it's not. This nothing. This is when we talk about lack of preservation. This is nothing you're seeing on the MRI itself. So these kits that we're analyzing, their MRIs are normal. It's only on the type of very detailed analysis that's being done that there are these differences in the density and things like this. That then you see that there's a difference, and by comparing it to the brain bank, you're able to see, wow, as a group, lower density or lower whatever. But just looking at the MRI in a clinical setting, they look fine. Yeah, it's just a different way of doing things.
Were those areas associated with hearing aid use? Did you look at those specific areas in your children that had used hearing aids?
So it wasn't looked at, we didn't look at it the same way. And you have to realize that kids with the hearing aids don't have speech perception. Mm-hmm. So we were really focused on we didn't really expect to see involvement at the higher level, so the focus was on the primary auditory cortex. So those were the main regions of interest that were selected.
One more question, big picture question. How has this work that you've been doing, how is it changing who you think you'll implant or not, or is it changing who you'll need more rehabilitation?
No, we're not. This is not data that crunching these numbers in real time. We're not like, oh, here's a new candidate, let's stick it in the model. This is very early on. This is like we have a massive RedCap database that we're just trying to get as much data into as we can. This is not ready for prime time. I would not use it at this point.
I'm just curious, people with machine learning experience, which is not me, have they hinted what that number might be? They will sometimes let it slip that 10,000 of these would be great, or that, that they're, based on the early performance of the model, those estimates start to emerge. Anything like that, or still?
Yeah, I don't know and there's different techniques, there's different types of, depending on what you're crunching, there's different numbers and there's different ways of doing machine learning, which is not, I'm not the expert in that either, although I've certainly had to read about it. I was just talking to Patrick about this, and he feels that technology is not the issue. It's getting enough data, that's always the struggle. So we're Patrick and I are well matched because I think we're the largest pediatric center, so we're certainly feeding a lot of data, but we're really looking forward to getting more data from our other centers. But it's not easy. And how to doing a multi-center study is really, really challenging. We did it a little bit in our R21, getting everyone on the same page. We have a great group, and we're really looking forward to that. So good question, but I don't have there's not like a set, we don't have like some target like we need to get to this. Yeah.
Regarding the audibility issue of these kids that wear hearing aids, Susan Mitchell published some nice work a few years back suggesting that children who had a period of hearing aid use prior to implantation had better phonological awareness after the implant was activated. And so that's it.
It fits with that, doesn't it?
It completely, and she said even if these kids had corner audiograms, we think they wouldn't get very much. They continued to use the hearing aid prior to that, helped them out down the road. But it wasn't with like all aspects of language development. It was really related to phonology and things like speech contours and
So
stuff like that.
which author are you?
Susan Mitchauer? I think.
Oh, yes, Susan, but the Ann Beers and her early work, they have similar findings as well, and I think a lot of people have forgotten that. It's always the latest thing, because, you'll periodically, I see this, some people just don't even bother to fit hearing aids anymore. Oh, your ADR says you're deaf enough for an implant. I'm a big fan of fitting hearing aids for all sorts of reasons that have nothing to do with this. I think it's important to train your parents. I think it's important to get everybody to, get all of their services in line. I think all the work up front is really, really important. So I've always been a huge fan. But I love the fact that there's this older data and now our data, which is consistent with that. I think it's really important, and I'd love to have them. I hope we just submitted that paper for publication, and I hope the word gets out and encourages people to do these kids soon, and then get them referred in soon. There's like two major barriers there.
But, the other point that when you mentioned the audibility with the speech intelligence, that matters a lot for these non-implant kids. That's actually, there's a lot of data to suggest that it's not just if you take a child with mild to moderate hearing loss, and you have 7 hearing aids on it, but if that hearing aid isn't fit to maximize audibility, the deficit shows up like 2 to 3 years down the road what the language looks like. So these kids with significant hearing loss are implant candidates. The SI, the speech intelligence, it doesn't matter that much. But these kids with mild to moderate hearing loss, maximizing that matters a ton. But you don't see that benefit early on. You see that benefit about 2 to 3 years down the road.
Great audience. Thank you very much.
Great, thank you so much.